Review. There was a 2013 study, so done, a while ago. But what it showed is about 63.4% of veteran patients had an ocular diagnosis other than refractive error on initial examination. That's a pretty high number if you think about it. So a lot of our veteran patients do have some type of ocular disease going on. This was higher than the previous study that looked at this, which was in 1972, which reported 21.1%. There was some discussion why that number might have increased from 21 to 63%. It might have just been because the population of the veteran patients has increased over that period of time. Other demographics to keep in mind when you're examining VA-type patients, the average age of the veteran patient is 62, and 80% of those are greater than the age of 50. I've never looked specifically in my clinic, but I think that we skew even perhaps a little bit older than that. 89% are male. And then when you think about the minority populations, depending on the location, the percentage of African Americans, as an example, is anywhere from about 12 to 29%, depending on the location. And all of these numbers, the percent male, the average age, as well as the amount of minority patients, all exceed that in the general population. Of that, in that study, they showed that 63 or so percent had some ocular disease. The most common diagnosis was glaucoma or glaucoma suspect, about 25%. And that was dealt with in the previous discussion. Cataract, about 5.9%. AMD, about 4.7%. And then diabetes and diabetic eye disease, about 13.8%. And in general, these numbers or these disease processes appear to be about similar in the veteran population versus an age-matched non-veteran population over the age of 50 with some variations, which we'll talk about as we talk about the individual issues. So when it comes to retinal disease, the topics we really want to talk about today are AMD, whether it's dry, non-exudative, or wet exudative, diabetic eye disease, which would include retinopathy as well as macular edema, and then briefly, time allowing, just a brief discussion of retinal vein occlusions as well. So when we think about AMD, AMD is a leading cause of vision loss in Americans over the age of 60. And obviously in the VA population, we see a lot of patients over the age of 60, so we do see a fair amount of macular degeneration. As many as 11 million Americans have some level of macular degeneration, and that number is expected to increase to about 22 million by the year 2050. In the veteran population, the study seems to indicate about 4.7% of the veteran population has some level of macular degeneration. This number is probably a little bit lower than some other population studies. In the general population, one number that's thrown around is about 6.12% of patients that have some level of drusen in one eye. So 6.12 versus 4.7, a little bit higher. One of the reasons might be that in this particular study that looked at the rate of AMD, there may have been an average, higher than average minority population in that study. And certainly we know that Caucasian Americans have higher rates of macular degeneration versus African American or Hispanic patients. And of those 4.7% in this veteran population study, 1.2% were diagnosed with drusen, 3.2% with dry macular degeneration, and 0.3% wet macular degeneration. So we're familiar with the signs and symptoms of macular degeneration, and obviously we know that macular degeneration affects the macula, the area responsible for fine or central vision. Early symptoms include gradual or sudden change in vision. Straight lines may appear wavy or distorted, metamorphopsia, and difficulty reading or seeing details in low light levels. But the one thing to keep in mind that a lot of patients with macular degeneration are often asymptomatic, and they might not know that they have macular degeneration until we, the doctor, tell them that, hey, you have some signs of macular degeneration. We'll talk about that a little bit more. As far as AMD screening, really, as I mentioned, patients with early AMD may be symptomatic or unaware of their diagnosis. So certainly if a patient complains of a complaint or a symptom suggestive of macular degeneration, obviously we're going to check for that. But we should really be looking for macular degeneration in the majority or a lot of our patients. So patients greater than 60 should all be screened for the presence of macular degeneration. And patients that are at high risk for macular degeneration, whether it be family history or other things, should also have an annual eye exam looking for the presence of macular degeneration. And this examination should obviously include the measurement of visual acuity, a dilated retinal exam, Amsler grid testing, and then other testing as indicated, whether it be an OCT, fluorescein angiography, photos. These are all helpful depending on the level of maculopathy in this patient. I mentioned earlier that unfortunately, some patients have macular degeneration and don't know about it. And very often they first present with macular degeneration and they already have vision loss at that time. One study said that 78% of patients presented with vision loss worse than 2,200 in one study. So these patients, by the time they got the diagnosis of macular degeneration, they already had significant vision loss. There's another study that specifically screened patients for eye disease. And in this study, what they found was when they sent these patients into a reading center, 25% of those patients were found to have macular degeneration at a reading center that wasn't picked up on clinical exam. So I think that the point there is that, we really need to look carefully in our patients, really examine their macula very carefully, use the OCT when appropriate to look for any signs of macular degeneration, because the sooner we can alert a patient that they have it, the sooner we can take some proactive steps to hopefully prevent it from getting worse, or at least notify the patient to tell us if they do have any symptoms associated with progressive macular degeneration. Risk factors, age, essentially as the patients get older, they're more likely to have macular degeneration. Race, as I mentioned earlier, Caucasian patients are more likely to have macular degeneration than other minority populations such as African Americans or Hispanic Americans. Smoking has been shown in multiple studies to be the #1 modifiable risk factor for macular degeneration. That's why I think it's really important if you have a patient that has early macular degeneration or family history or just wants to be proactive, wants to know what can I do to prevent myself from getting macular degeneration. One of the first things to talk to about is smoking cessation. Very, very important in my mind. Other risk factors, family history, right? If one of your parents has it, your chance of getting it is increased as well. And then there's some new research starting to look at some genetics and genetic testing and that sort of thing, and whether or not there's a role there. UV exposure, poor diet, and obesity. So all these things are risk factors. And if you kind of look at these risk factors, you realize that a lot of these risk factors are present in our VA population, right? Older patients, some of them smoke, quite frankly. Some of them have a very poor diet. So they're really are at higher risk for macular degeneration. Again, we're familiar, there's two forms of macular degeneration, the dry and the wet or neovascular form. The dry form is characterized by geographic atrophy, drusen, and RPE hyperplasia. The dry form is the most common, and it's about 90% of all macular degeneration is a dry form. That's good news because that means only about 10% is the wet or neovascular form, which is characterized by subretinal blood and or subretinal fluid from a choroidal neovascular membrane. The unfortunate thing is that even though only about 10% of patients have the wet form, those patients in general have much more severe vision loss, and wet macular degeneration accounts for about 90% of all legal blindness from macular degeneration. There's a classification system for AREDS from the AREDS study that helps us classify patients with, and I said dry AMD, but really it should be all AMD. But it helps us classify the patients, and I do think it's useful to classify the level of maculopathy in a patient with AMD in order to kind of understand their risk of getting worse and how often you should see these patients. And some people would argue that the AREDS classification system is a little bit burdensome, and I could agree. So this is what I like to use. But if there's another classification system that you like to use, I think that's perfectly fine. But again, I think some classification system is useful. So in the original classification system that came out of the AREDS study, AREDS category 1, no AMD, no or a very few small drusen, less than 63 micrometers in diameter. AREDS category 2, this is when we move into early macular degeneration. These patients have multiple small drusen, a few intermediate sized drusen, 63 to 124 micrometers in diameter, and mild RPE abnormalities. Intermediate AMD, this is AREDS stage 3. This is when you have numerous intermediate drusen, at least one large druse. I didn't realize that drusen's plural and druse is singular, so if you ever get on Jeopardy, that could come in handy. But at least one large druse greater than 125 micrometers in diameter. And then geographic atrophy non-central. That's category 3. And then we move over to category 4. This is when, unfortunately, things get very bad. This is when you have advanced macular degeneration, either characterized by central geographic atrophy in the macular area itself or neovascular AMD. Now, again, I use this system. I don't measure the size of drusen. Obviously, in a clinical setting, that's really not useful. It's too cumbersome and that sort of thing. But I kind of, through experience looking at drusen and seeing these patients, you kind of get a good gestalt of what's small, what's intermediate, and what's large. So I do like to use this so I know how frequently I want to see these patients back and their chance of advancing to advanced macular degeneration. It can also help us determine when might be the appropriate time to start vitamins. So the treatment of dry macular degeneration really revolves around the prevention of progression through vitamins, nutrition, and lifestyle changes. So we can counsel the patients with dry that these are things they can do to hopefully slow down the progression and prevent it from advancing from dry to wet macular degeneration. No smoking. I talked about that earlier. Very important to talk to patients about that number one modifiable risk factor. There's some studies out there that indicate, though, that most patients were not made aware of the dangers of smoking. So I think that's very important. A healthy diet, UV protection, and then vitamin supplementation when indicated. And it's a little beyond our scope to go into a long discussion about vitamins. But from the AREDS and most recently from the AREDS 2 study, it gives us some indication of when is the appropriate time to start vitamins and how it can help slow down the progression of macular degeneration. The other important thing to look for in our patients with dry macular degeneration is we want to be able to determine if the patient converts from dry to wet as soon as possible, because the studies say that the sooner we can treat these patients and the sooner we can get them treatment, the better off their visual acuity be in the long run. So anything we can do to detect the conversion from dry to wet is going to be advantageous to that patient. Wet macular degeneration, and I'm not going to steal Dr. Sway's thunder because she's going to be talking about this later, but obviously as an optometrist, if we see a patient that we feel has wet macular degeneration, this is going to be an urgent referral on our part over to a retinal specialist, and obviously that retinal specialist is going to probably start treatment with anti-VEGF agents, whether it's Lucentis, Avastin, Eylea, or Beovu for those patients in order to maintain their vision. So just, a couple quick examples here before we move over to diabetic retinopathy. But this is an example of a patient with very mild macular degeneration. You can see they have very good vision at 20/20 minus a letter or two each eye. And I think you can perhaps appreciate this, just a couple, small drusen just by their macula area. And I did an OCT on this patient. And again, on the OCT, I think you can perhaps appreciate some small drusen, but nothing, really too, untoward. So, in my mind, this is a patient with mild macular degeneration, which would be stage 2 versus the AREDS 2 study, AREDS study rather. This is a patient, I think patient education would be important. Discuss with them lifestyle changes, things they can do, no smoking, eat healthy, UV protection, that sort of thing. Perhaps give the patient a home AMSA grid to take home to help them look for any changes, or at least tell them, to monitor each eye separately, looking at a straight line. Or sometimes I tell patients to look at their blinds in their house, because I find that's maybe a little more realistic than looking at a grid. And then I would probably like to see a patient like this back at about 6 to 12 months in order to monitor the progression of their macular degeneration. Here's a patient with moderate macular degeneration, stage 3, according to the AREDS study, and, 20/30, but the patient also has a little bit of a cataract as well, as I think you can maybe tell from the photo. But I think here you can see the patient has multiple intermediate drusen that would put them into stage 3. And on patients like this, I do like to get an OCT, because sometimes, especially in the right eye, sometimes you can be fooled and you can see a little fluid when you don't expect it. Here's the OCT on this patient. I think we can appreciate some rather large drusen in that right eye, some smaller drusen in the left eye with a little RPE disruption, but no apparent fluid or anything in this patient. So this would be a patient with moderate or intermediate macular degeneration, stage 3 for the AREDS study. Again, patient education, discuss lifestyle changes. And I think this is probably an appropriate time to start the patient on an AREDS 2 supplementation containing lutein and zeaxanthine without beta carotene. Also, I would give this patient a home AMSA grid, and I would want to see this patient back, a little bit sooner, because this patient's going to be at a little higher risk for conversion from dry to wet macular degeneration than the previous patient. So I might want to see this patient back 3 to 4 to 6, every 4 to 6 months or so, depending on other factors. This is an unfortunate situation here. This is a patient who in the left eye now has wet macular degeneration. The previous time we saw the patient, they're about 20, 40-ish, there's some cataracts as well in this patient. But now the vision in the left eye has dropped to 20/70. I think you can appreciate a small hemorrhage in the macula area. And when we do the OCT here, you can see the right eye looks nice and flat with a nice foveal pit. But you can see here the left eye, there's certainly some edema there, and there's some intraretinal bleeding, as well as a choroidal neovascular membrane right on the RPE. And you can see in the map there that there's some elevation, in this patient. So this is a patient that unfortunately has converted to wet macular wet macular degeneration in that left eye. This is going to, cause us to get a prompt referral over to the retinal specialist for most likely anti-VEGF treatment. This is a patient too, I would advise, again, AREDS 2 supplementation to protect the fellow eye. And here's the OCT angiography, and on the OCT angiography, you can also see the little choroidal neovascular membrane on the top, consistent with the diagnosis of wet macular degeneration. And if you were to do a traditional fluorescein, you can also see some leakage in that patient. And again, these are all ways to confirm that the patient does in fact have wet macular degeneration. So, again, as way of a short summary, dry macular degeneration, frequent monitoring, home AMSA grid, or consider home monitoring as well, lifestyle intervention, vitamin supplementation when indicated, especially at that intermediate or worse stage. As an optometrist, if we see a patient with wet macular degeneration, that's really going to, necessitate a referral over to our retinal specialist at the first sign of conversion, probably for anti-VEGF injections. Still keep in mind vitamin supplementation, consider home monitoring, And then, unfortunately, some of these patients, even in the best hands, may lose some vision. So certainly keep in mind low vision referral. If that's not something you do, refer it to one of your partners or colleagues that does low vision. I want to switch gears and just talk about diabetes for a little bit as well. Diabetes is unfortunately super, super common in the United States. Approximately 34.2 million Americans have diabetes. It's roughly about 1 in 10. About 88 million adults, about 1 in 3 have prediabetes. And the fear is that if left on their own, eventually a lot of these patients with prediabetes will convert to diabetes. So if we think we are seeing a lot of diabetic patients now, a lot of the studies show us that in 5 or 10 or 20 years from now, the amount of patients with diabetes is going to rise quite precipitously. 30% of patients with diabetes have some level of retinopathy. And actually, it's not uncommon for patients with prediabetes to also have some retinopathy. And one study said about 7.9 to 12.3% of patients with prediabetes have evidence of some retinopathy. So even if the patient comes to me and says, well, I don't have prediabetes, I don't have diabetes, I'm just pre-diabetic, I still recommend that they do see us on a yearly basis so we can look for any signs of retinopathy. About 10% of those patients have vision-threatening disease, whether it's severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, or diabetic macular edema. And about 50% of patients with diabetes will develop diabetic macular edema at some point over the course of the disease. In the veteran population, they looked at studies again, and they found that 13.8% of patients in the veteran population were seen for diabetic or diabetic eye disease related issues. Of that 13.8%, 10.2% had no signs of retinopathy, 3.5% had some level of retinopathy, which is pretty consistent with the general population. It might actually be a little bit on the lower end of the published records, the published studies. And the reason that we think it might be is being in a closed system in the VA like we are, it's a little bit easier to make sure that the patients are getting diabetic checks yearly. And also, there's some incentives for the doctors to really control their diabetes and their comorbidity. So those numbers might actually be a tad lower than the general population, which is good. Certainly all patients with diabetes should get an annual dilated retinal exam, and we're all familiar with that. Type 1 patients should really have their initial examination per the ADA and American Ophthalmology Association, other associations, 3 to 5 years after initial diagnosis. And type 2 patients really should get their first screening at the time of diagnosis, because studies tell us up to 40% of patients may have retinopathy at their time of diagnosis. And very often these patients with type 2 diabetes have type 2 diabetes for several years before it's diagnosed. Studies do tell us, though, that approximately 1 in 4 patients with diabetes are not receiving annual exams. So even though sometimes I get tired of talking to my diabetic patients and explaining to them the importance of getting a dilated retinal exam, even if they feel they have perfect vision, we can't lose sight of the fact that that's a very important message, because studies tell us a lot of patients with diabetes are not getting their yearly retinal exam. There's certain factors which influence the development of diabetic retinopathy, and just a few of them are control of blood sugar, duration of disease, and comorbidities, especially hypertension. So we know that patients with better hemoglobin A1C control are less likely to get diabetic retinopathy and less likely to have it advance. And the longer a patient has type 2 diabetes, or type 1, but we see more patients with type 2, the longer a patient has diabetes, the more likely they are to have retinopathy. And then those patients with comorbidities, especially hypertension, especially uncontrolled hypertension, are also more likely to have diabetic eye disease. There's tools in our in our clinics that we can use to help us take better care of our patients with diabetes. Wide field photos are a very nice way to look way in the periphery. Does not take the place of a dilated retinal exam, but it can be a nice adjunct. And also, sometimes it's hard. The patient's moving around. They have a cataract. They're not being cooperative. It's nice to take a nice wide field photo and look at it to make sure you're not missing anything on your clinical exam. OCT, I used to think I was pretty good for looking for macular edema until I got an OCT, and then I realized OCT is much, much better than I could ever hope to be. Fluorescein, wide field fluorescein, usually done in some of the ophthalmology clinics, can also be a great way to look for any, diabetic retinopathy, especially in the periphery. And sometimes we see changes in the periphery, whether it's ischemia or neovascularization, that we didn't appreciate on clinical exam. And then OCT angiography, a relatively newer technique that some clinics are starting to incorporate to look for ischemia as well as other things. So these are tools that can certainly help our clinical exam. Just real briefly, we'll just, in the next couple minutes, just go through some the classification system here. Mild non-proliferative diabetic retinopathies. This is when you get microaneurysms or dot blot hemorrhages. These patients generally we can see back educate the patient and see them back in a year. Moderate non-proliferative. This is when we get more hemorrhages, some cotton wool spots, venous beading, and ERMA, those pesky ERMA to a mild degree. These patients you want to take a little closer look at and see these patients probably in about 6 months. From here, we move into the severe or very severe non-proliferative diabetic retinopathy. And we probably remember from our days in school the old 4-2-1 rule, right? If they have marked hemorrhages in all 4 quadrants, venous beading in 2 or more quadrants, or marked ERMA in 1 or more quadrant, that means they have severe non-proliferative diabetic retinopathy. If they meet 2 of those 3 criteria, then they have very severe non-proliferative diabetic retinopathy. And there's some new research, which I'm hoping Irina will maybe discuss a little bit later, that this is really perhaps a good time to intervene on these patients with anti-VEGF to prevent them from reaching the proliferative stage. And about 50% of patients at this stage will progress to proliferative diabetic retinopathy within a year if there is no intervention. From there, we move into proliferative diabetic retinopathy. This is when we get neovascularization with a neovascularization of the disc, NVD, or neovascularization elsewhere, NVE. And you can see a couple examples there in the photos. And this is obviously once we as optometrists start to see proliferation, we're going to want to send those patients over to the retinal specialist within 2 to 4 weeks for some treatment. High-risk PDR, these are patients that have larger areas of NVD or NVD with a preretinal or vitreous hemorrhage, or moderate to severe NVE with a preretinal or vitreous hemorrhage. These patients are at risk for severe vision loss, so this is really an urgent retinal consult within 24 to 48 hours. So just, we talked about this, but, mild, moderate, we can keep those as an optometrist and see them back. But once we get that moderately severe to severe stage, I really think that's a good time to send them over to the retinal specialist to at least consider treatment. Obviously, PDR, we're going to send those over for treatment as well. And it's always important to educate our patients with diabetes about the importance of blood sugar as well as blood pressure control, and then to get the PC involved, primary care physician involved, if their hemoglobin A1C is not to the appropriate levels. Just real quickly, diabetic macular edema, about 50% of patients with diabetic retinopathy will develop diabetic macular edema at some point within their disease. It can happen at any stage of diabetic retinopathy. So even patients with mild disease can get diabetic macular edema. And it's very important to always look for diabetic macular edema because really diabetic macular edema is more responsible for moderate vision loss among patients with type 2 diabetes than actual diabetic retinopathy. And we used to think about center involved versus non-center involved. We used to think about clinically significant macular edema. We had definitions of clinically significant macular edema. But now with the advent of OCT, we really start to think about non-center involved and center involved. So if the smallest little ring there on our OCT is involved with the thickening, we're going to call it center involved. If it's not involved, then it's non-center involved. So this is an example of a patient It's close, but it's non-center-involved diabetic macular edema. Here's a patient with center-involved diabetic macular edema because that very center ring on the OCT is affected. These patients with diabetic macular edema, we're going to refer those patients over to the retinal specialist within 2 to 4 weeks, and the retinal specialist is going to consider what type of treatment might be the most appropriate for that patient. Also, again, patient education, blood sugar, blood pressure control, and primary care involved as needed. I don't want to go over, but just real quick, retinal vein occlusions, also very common. The second most common retinal vascular disease, second to diabetic retinopathy. 16 million people worldwide, and you can see some of the prevalences here. The VA patients seem to have a slightly higher prevalence of vein occlusions versus age-matched studies. And it might be because we have older patients and we have a higher percentage of male patients that are more commonly do get BRVOs and CRVOs, and more systemic risk factors as well. And, just some examples here. You can see some nice examples of patients with BRVOs. And here's an example of a patient with a BRVO and macular edema. Here's an example of a patient with a BRVO, and you can see some neovascularization there as well. And a patient with a CRVO and some edema from that CRVO as well. These patients, when they have these vein occlusions, again, that's gonna prompt a referral over to the retinal specialist, especially if that patient has macular edema or neovascularization, and then they'll be treated appropriately, whether it's with anti-VEGF steroids or laser. And also, it's important to get to the underlying etiology for these patients. So you might want to work with a primary care physician to get at the underlying etiology. Diabetes and hypertension are most common. Others, hyperlipidemia, coronary artery disease, altered platelet function as well are potential reasons. So really, in conclusion, retinal disease is common in VA patients. Things like macular degeneration, like diabetic retinopathy, like vein occlusions. We didn't talk about some of the other things we also see in this type of patient, whether it's retinal plaques or hypertensive retinopathy. And, the key as an optometrist is really early detection through screening and comprehensive exams and prompt referral over to our retinal specialist colleagues for appropriate treatment, because that can really help save these patients' vision. So with that, I'm going to see if we can turn it over to Irina or Rishi, whoever takes it next. And I just wanted to say thank you.
Yeah, thank you. Thank you, Steve, for that talk. And we're going to take questions at the end. So please, for the panelists, feel free to put those questions in the chat box. And Irina, you can take control of the slides and go on to your presentation. Irina is coming to us, Dr. Sui is coming to us from UCLA Doheny Eye Institute, and it's my pleasure to introduce her for today's program. And she's going to cover some of the, Steve covered very nicely the sort of methodology by which we do this, but the studies are what we're going to hear from Dr. Sui about with regards to the outcomes.
Thank you for that introduction. I think I turned off my mute. Can you just confirm that you can hear me?
Yes, we can hear you.
Okay. And thank you for that good segue, Steve. So I've been at the West LAVA for about a decade now, and I'm going to talk to you about intravitreal anti-VEGF injections in this veteran population that we treat. This is a topic that's near and dear to my heart, as we serve 10 feeder clinics. And so we're always trying to improve our intravitreal injection clinic, both for safety, efficacy, and the patient experience, and constantly thinking about how can we make things better. So with that in mind, there are 3 key points to the study. One is that treat and extend is a popular and effective treatment strategy when using anti-VEGF for neovascular AMD. 2, anti-VEGF is also first-line treatment for diabetic macular edema, despite the fact that there are other options as well. And as a corollary to that, we don't have to treat all diabetic macular edema. I'll talk about that more later. And lastly, I just wanted to present some data that we have collected at our clinic about how injection clinic was able to rebound after the lockdown in 2020 and what it looked like after lockdown. So what is the most common procedure in ophthalmology? This is a talk about anti-VEGF, and the answer is by far intravitreal anti-VEGF injections. We've been in this era since 2005 when Avastin and Lucentis first came out. And before then, cataract surgery was the most common procedure in ophthalmology. Quickly, about in 2007 or 2008-ish, intravitreal anti-VEGF injections surpassed cataract surgery. And since then, while cataract surgery has about doubled, intravitreal injections have increased exponentially. So as we just heard, the most common reason for intravitreal anti-VEGF is neovascular AMD. It's a leading cause of vision loss in individuals over 50 years old, particularly of white ethnicity. Risk factors include family history, complement factor H, smoking, UV light exposure, and heart disease. Signs of neovascular AMD include soft confluent drusen associated with hemorrhage, RPE changes, cystoid macular edema, intraretinal fluid or subretinal fluid, as well as pigment epithelial detachment, as seen in this picture on the right. So in the picture, you can see hemorrhage, drusen, RPE changes on the color fundus photographs, and the OCT points out both subretinal fluid and maybe a pigment epithelial detachment there as well. Patients present with new sensoral scotomas and metamorphopsia, and we use OCT guidance, which is able to help not only diagnose, but monitor treatment down to micron level of precision. So we know from the original Marina and Anchor trials that monthly injection of anti-VEGF can increase vision, or at least stabilize it in most patients, especially when CNV is treated before atrophy and scarring have occurred. With monthly injection, good vision gains can be retained all the way out to 2 years. But monthly injection for 2 years is a lot on patients as well as clinic, particularly if both eyes are being treated. That is potentially a visit every 2 weeks. Well, treatment can be divided into an induction phase, which is typically 3 monthly doses, followed by a maintenance phase, which would be keeping the retina dry after the neovascular changes have regressed. Although these initial trials, Eylea was FDA approved based on non-inferiority during the maintenance phase of treatment, using Q2 month rather than monthly during the first year, and then a modified Q3 month dosing in the second year. And this gave vision results as good as Lucentis monthly with less injections. In the real world, we often see that Eylea is more durable and lasts longer and perhaps dries quicker than Lucentis. So we oftentimes will use Eylea if patients are not responding or recurring with Lucentis. So although these initial trials were done with fixed dosing, what are reasons in the real world to deviate from fixed dosing regimens? Well, for one, neovascular AMD is a heterogeneous disease with variable natural history, variable treatment response, and variable genetics. VEGF suppression varies between patients based on these factors, and treatment burden can be very high for patients, particularly if they come from very far away, as many of our patients do, and they also have to battle traffic and other transportation issues. In addition, there are potential risks with each injection. The most dreaded one would be endophthalmitis, but also in COVID era, they risk getting COVID as well each time a patient comes to clinic for an injection. And lastly, many patients do well without frequent fixed treatment, so it is best to kind of tailor treatment and find which patients can be treated and extended. So what are other dosing approaches? On the opposite end of the spectrum as fixed monthly doses would be as needed, or PRN, which is when you only treat if fluid is recurring on OCT. This is suboptimal as allowing the CNV to recur and come back oftentimes leads to reduced vision over time. So a middle ground approach, rather than fixed treatment or PRN, would be treat and extend. So let's talk about treat and extend a little bit more. So this is just showing you that continuous fixed can be thought of as monthly, meaning once a month, and there are many trials that did that, particularly the ones that Lucentis used to get FDA approval. Also, you could do bi-monthly or quarterly, meaning just regardless of what the OCT shows, give an injection every 2 months or every 3 months. And then there's treat and extend, which is the most commonly used method, and what we're going to talk about a little bit now. So with treat and extend, patients are treated monthly until the retina is dry on OCT. And then each time a patient comes in, an OCT is taken and an injection is given. So this is very practical because you don't waste the visit. You don't have a patient come in and not check a picture. You don't have a patient come in and not give a treatment. So if you're treating every time, what is the OCT for? The OCT, whether it's dry or wet, helps to determine what the follow-up interval is. So if the OCT shows that there is no choroidal neovascular activity, patients can be extended, usually by 1 to 2 weeks for their next visit. And if during the extensions, let's say a patient is extended to 8 weeks, and if they come back at 8 weeks, but there's fluid, then they would be reduced to a month again, or down to 6 weeks. And then you would retreat monthly until the OCT is dry, and then try to extend again. So the American Society of Retina Specialists Preferences and Trends Survey responses every year asks, how do retina specialists around the country treat neovascular AMD? And by far, the majority use some version of treat and extend, because again, this is very practical for both the patient and the clinic. You utilize each visit to the maximum by doing an OCT and treating. And then also you can find which patients can be extended longer and don't need monthly injections. The second question is, after 2 years of injection therapy, how often are people treating neovascular AMD patients? And by far, most people are not needing injections every month. More than 50% are extended to quarterly, or 1 injection every 3 months. So switching gears a little bit to diabetic retinopathy. So 1 in 10 people in the United States have diabetes, which equates to about 30 million people. 50% of patients with diabetes have some degree of diabetic retinopathy. In the veteran population, rates of diabetes and diabetic retinopathy are thought to be perhaps even higher than the general population. Risk factors for developing retinopathy include glycemic control, hypertension, high cholesterol, as well as how long a patient has been a diabetic. The most common cause of decreased vision in diabetic retinopathy is diabetic macular edema. Treatment options include anti-VEGF injections, steroid injections, and focal macular laser. Of these 3 options, anti-VEGF injections is first line because of its good safety and efficacy profile. Steroid injections carry the risk of cataract if the patient is phakic, as well as possible ocular hypertension or even glaucoma if there is a steroid response. Focal macular laser is good for some patients with a particular pattern of circinate exudate if you can target a leaking microaneurysm, but it's not good for foveal involving and central involving anti-VEGF because you risk causing a central scotoma if you laser the FAZ. In addition, besides treating macular edema, other benefits of anti-VEGF in diabetic retinopathy include treating retinal neovascularization or the retinopathy itself, and if present, anti-VEGF can also treat neovascular glaucoma. So the original trials for diabetic macular edema were done with Lucentis in the RISE and RIDE trials. These were 2 parallel phase 3 studies that enrolled diabetic patients with moderately decreased vision and center-involving macular edema as determined by OCT. Patients were randomized to 2 different doses of Lucentis, or a sham injection, for 36 months, with laser being available as a rescue in all 3 groups. And by far, you can see that the 2 doses of Lucentis offered large vision gains starting at about 6 months, and they were maintained when given monthly injections all the way out to 2 years. In contrast, the sham group, who was able to be treated with laser, maintained about the same vision. And there were similar results in the EYLEA studies, which were called VISTA and VIVID. There were also 2 parallel phase 3 studies with similar inclusion criteria. The difference was that after loading doses, EYLEA was given either monthly or every 2 months, with also laser available in each group. And the results, as shown here, were very similar. At about 6 months after injections, there was an average of 10 to 12 letters gained, and this was maintained throughout the 2-year period when patients were on fixed interval dosing for diabetic macular edema. Besides treating macular edema, you can see from this example that anti-VEGF can actually regress stages of retinopathy. And in fact, in the RISE and RIDE studies, patients in the treatment arm had a regression of retinopathy stage by at least 2 stages in over 50% of patients. So rather than doing laser, anti-VEGF can be a good option. Now, we still oftentimes do combine anti-VEGF with laser for treating PDR. This combination approach, though, allows less laser to be put in oftentimes, while maintaining the long-term effects of treatment so that patients do not have to get injections quite so frequently or quite so often. So a study from the DRCR network looked at management of eyes with center-involving DME on OCT and good vision, and asked the question, do we really have to treat all DME that we find with OCT? Because oftentimes we are picking up DME now on OCT before patients have decreased vision or before we would otherwise even see it on clinical exam. And I will say that within the VA, we're picking up a lot of early diabetic retinopathy and DME because of the excellent teleretinal reading centers that have been set up for over a decade now. So it's a really excellent part of VA care is how early we are finding diabetic retinopathy in our diabetic patients. So this study was called Protocol V, and basically, like I said, it looked at center-involving DME on OCT in patients that had good vision. And it was found that there was no difference in vision loss at 2 years between initially watching carefully versus treating with anti-VEGF or treating with laser. And EYLEA was available to the laser and observation groups if vision decreased from baseline or if the diabetic macular edema worsened on OCT as well. All 3 strategies, whether you observe first and treat later when things worsen, or if you treat right away when the vision is still good, they all resulted in a mean vision of 20/20 at 2 years. So based on these results, many retina specialists and patients might choose initial observation for center-involving DME if the vision is good, and only treat if the CME or the vision worsens. And this is a conversation to have with patients. And I would say that most patients, if their vision is good, they don't have any symptoms, and their diabetes is well controlled or on the way to being well controlled, they choose not to start the injections for good reason, because they don't have symptoms, they don't want the risk, and they don't want the hassle. Occasionally, there are patients that want everything done, and they fear going blind more than the burden of the treatment itself. So it is a conversation that is very important to have with the patient and to decide with the patient. But based on the study, basically the algorithm is if the vision is good, 20/25 or better, and I would say there's some wiggle room there. I would say 20/30, 20/40. Sometimes I will still discuss it with them and bring them back if the patient doesn't have any symptoms and would prefer to be watched. But it is important to watch carefully with follow-up in 2 to 3 months with repeat visual acuity testing and OCT. And if either of those things worsen, either thing being vision or OCT, then we should and can start treatment then. And so the reason for not treating right away, it is twofold. One is if we're following, we have the opportunity to treat later and regain vision. So that is shown in the patient on the left. This is a patient that presented with 20/25 vision at baseline, chose not to get an injection at this time, came back, was followed regularly. This just shows the 1 year, but throughout the year, slowly vision got worse and the macular edema got worse, then started treatment. And by the second year, was able to regain vision to 20/20, and the macular edema is well treated. The second reason is, besides the fact that you can catch up in DME later, a large portion of patients actually can resolve on their own and not need an injection, as shown with this patient on the right, where the patient presented with quite a bit of macular edema on the OCT at baseline. You can see that the vision was 20/20. He didn't have any symptoms. And with glycemic control and blood pressure control, the diabetic macular edema went away on its own. Fortunately, we don't know which patients are going to worsen and which can resolve on their own, which is why follow-up is very important. So in summary, for Protocol V, most eyes initially managed with observation who presented with good vision did well in the long run. In fact, 66% of eyes in the observation group did not get worse and did not need to be treated, and 30% had spontaneous resolution of diabetic macular edema at 2 years with just observation. All right, and lastly, for the last 5 minutes of my talk, I wanted to talk about injections during COVID. Of course, it's great to talk about the ideal situation. Ideally, we would treat and extend all AMD patients and they wouldn't be lost to follow-up. And ideally, we would be able to watch all diabetics with good vision and they wouldn't be lost to follow-up. But pandemic or not, the reality is, in the real world, patients are busy, especially older patients and diabetic patients, not just busy, but they have barriers to coming back to clinic, whether it be other health issues, transportation, et cetera. And so the pandemic is just another factor of what made patients be lost to follow-up. During the pandemic, we quickly pivoted to have new protocols in place to prevent COVID spreading. That included universal masking, social distancing, increased ventilation with air filters placed around clinics, rearranging waiting rooms to comply with social distancing, as well as tracking what is the maximum safe clinic volume that we can still have while doing all these things. In addition, we all modified our equipment, which included a thorough wipe down in between patients of all surfaces, including doorknobs and door handles, using disposable lenses and placing plexiglass on all slit lamps, which were also wiped down between patients. So the question that we asked was, in our racially heterogeneous demographic population, in a large catchment area in LA, how did the lockdown affect intravitreal injection clinic? We looked at volume, demographics, non-ophthalmic factors, as well as ophthalmic factors in 3 time periods. A 7-week control group of 2019 was used, and we specifically were interested first in 7 weeks of California state mandated lockdown in 2020, and then we compared with 14 weeks post-lockdown to see what happened with injection clinic in the recovery of lockdown period. So this is a terrible slide because it's so small, but what it shows is that during the lockdown period, there were more Hispanics that came in than the year prior. This is interesting and notable because, as we know, Hispanics were a vulnerable population during COVID, oftentimes with more multi-generational housing situations, and also oftentimes being essential workers where they were forced to leave the house and forced to not shelter in place for practical reasons like having to work in order to make money and to feed their families. So second is looking at the ophthalmic data. And this we found to be a physician-determined factor. Basically, we intentionally prioritized AMD patients to come in during the lockdown period. And if a diabetic patient did not have a change in vision, we encouraged them to reschedule for afterwards. So based on physician triaging and screening of patients on the phone, we had more AMD patients come during lockdown than the year before. And lastly, looking at systemic comorbidities, we did not on the phone screen patients, ask them about what were the risk factors for getting COVID and being sick if they got COVID. But we found that during the lockdown period, patients with high-risk systemic comorbidities that would make getting COVID more dangerous for them, patients did not come in during that period. And that makes sense. And we consider that a patient decision-making factor, that patients themselves, due to high risk of having COVID and COVID complications, would have chosen not to come in during the lockdown period. We also looked at psychiatric conditions, which are higher in veteran population, particularly PTSD, and found that there was no difference in terms of psychiatric conditions and who came in during COVID. Post-lockdown, I'm not going to show the data, but I'll just describe it to you. And I forgot to mention that during COVID lockdown, injection clinic and all clinic volumes went down to 50%. Immediately after the lockdown was lifted, injection clinic volume went back up to 100%, despite all of our other clinics staying at about 50%. So what this means is that patients themselves realize the importance of coming back for injections, and that's a good thing. As soon as they were able to, they did come back for treatment. However, don't be fooled. Just because the volume did go back to 100%, when we looked more carefully, we saw that patients who returned during lockdown still had less systemic comorbidities compared to the 2019 group. Whether this is because they couldn't come in because they were sick from COVID, or they chose not to come in because they were scared of getting COVID, it is important to be mindful that there is a high risk group of patients out there that may be undertreated despite the restrictions being lifted. And then lastly, we saw a rebound in the diabetic macular edema patients coming in, and that makes sense because we had asked them not to come in if there was no vision change and to reschedule. So they all came back during the post-lockdown period. A few other COVID and anti-VEGF considerations. We now try to treat the same day as the visit to avoid patients coming back, where in the past we would offer patients, if it wasn't urgent for diabetic macular edema, to schedule, but we try to encourage them to get the treatments to avoid coming back. Also, during COVID, we started doing bilateral same-day injections, which we were hesitant to do beforehand due to increased risk of endophthalmitis occurring in both eyes if you inject both eyes on the same day. However, our infection control precautions are so strict now. We have patients wear a new mask, and of course, everyone in clinic is wearing a mask. We tape the mask, and so we feel that it is a risk worth taking to decrease patients coming back for a second eye injection in a short period of time. And so once again, to wrap up, the key points of this talk was that treat and extend is a popular and effective treatment strategy in neovascular AMD. Anti-VEGF is the first-line treatment for diabetic macular edema and diabetic retinopathy. And you don't have to always treat it if vision is good. You can watch and treat only if vision or the DME worsens. And lastly, the West LA intravitreal injection clinic did rebound rapidly after the COVID-19 lockdown, emphasizing how important injection clinic was both to patients and to us as well. Thank you so much for your attention.
Very nice talk. Thank you very much for that. Really appreciate your talk today, and both of you have done a fantastic job. So now we're going to go on to our panel discussion. But before we go on to the panel discussion, I would like to ask Evelyn Moore to come and discuss for a little bit about her organization, what they do for veteran care. I'd like Evelyn to, Evelyn, are you on the camera? I can't see you right now. 11 Lewis, there you are.
Yes.
Great. So Evelyn, why don't you tell everyone a little bit about your organization and yourself, and tell us about what you all do.
Sure. I'm a family physician by training, and we began this foundation, the Veterans Health and Wellness Foundation, about 8-9 years ago. As a family physician, I sort of look at veterans and within the context of their families and the issues that they have around their health. And so as we talk about this, the say, can you see vision issues within the veteran population, this is exactly the kind of thing that we like to partner with organizations to do, so that one, we can get this information out to healthcare professionals, but also look at how we can get the same type of information out to veterans and their family members and their community members, so that they better understand and can better advocate for themselves when they're being seen by this. One of the speakers said earlier that the VA can't always get all of the veterans in and seen by those at the VA. And so many end up being seen outside of the VA by civilian providers. So it's important that they have a foundation, a basis for understanding not just the disease, and in this case, ocular diseases, but how they relate to that veteran and perhaps to that veteran's service, because some of the unique positions that they can often find themselves in. And so, again, our foundation is there to sort of bridge that gap, if you will, of the information and knowledge around certain diseases, injuries, and illnesses that are unique to that population, the impact that those things have on their families, and also educating, in particular, civilian healthcare professionals and allied healthcare professionals about how to better understand military culture and the impact of service on the veterans' health. And we begin doing that by having them answer one simple question or ask one simple question of people who are under their care. And that is, are you a veteran or have you served? Because one of the key things they miss oftentimes is asking that question. And if you don't ask that question, you can't make that association between the injury, illness, or disease and perhaps the impact of that person's service. Mm-hmm. So that's where we are. And that's what we try to do. We strive to ensure that we look to create a world where all veterans and their families can live healthy and well lives, undiminished by their service-related health concerns. So thank you all again for what you're doing here.
Yeah, no, thank you, Dr. Lewis, for what you're doing. So I just wanted to pose this, Dr. Ferrucci and Dr. Sui. Do you hear from your patients about their issues with access to care in the VA system? And what sort of things are you doing to help with that? Or do you have a way of, in this VA system, to kind of get them the right care they need? So let's start off with Dr. Ferrucci, maybe for a second.
Unfortunately, we're in our situation, myself and I, we're in Los Angeles. It's a very heavily populated area. There's a large veteran population. So we do our best to take care of as many patients as we can, but unfortunately, we're not probably as well staffed as perhaps we would like to be. So there are delays, but I would say that once the patient gets into the system, they're very well taken care of. So I think the problem sometimes is getting that initial visit into the clinic, but once they get in, they're very well taken care of, and we're able to get the patient the appropriate treatment once they get in. And it's through working with nice retinal specialists like Dr. Sway, who's always willing to go out of her way to make sure the patients get prompt injections that we're able to do that.
Mm-hmm. Dr. Sway, did you want to make a comment on access to care? Have there been enough resources put forward, for example, for drugs and imaging and all those sort of things in your VA system in Los Angeles?
I would say yes, that we have, at our site particularly, we have many resources, both in terms of OCTs and cameras and technicians. I think one issue is the catchment area is so large that driving in and the travel can be an issue for some patients, particularly if they need a family member or friend to drive them. And so to ask them to come monthly for a 2 to 3 hour each way trip can be a burden. And we do have a mechanism to refer patients to a local retina specialist closer to where they live to get treated. And a few that live far away do take that option. I am touched to see, though, how many patients prefer to come to us. Like Steve said, once they are in the system, I do feel like there is a sense of connection with them and a sense of pride for them to stay in the VA system if they at all can. And there's also buses that can bring them in. And so we do have the option to send them out, which we sometimes use, but not that often.
Yeah, that's a great point. Actually, my wife is a VA primary care physician. That's one of the reasons why I love doing this program. And one of the things she tells me a lot is that there are people in my Cleveland clinic who are physicians, who are staff doctors, who come to the VA for their care because they believe in the access they've been able to achieve and what the VA has stood for with regards to its ability to care for the veteran population. So it's been a wonderful experience for them as well. Dr. Lewis, are there some specific initiatives you have going on this year that you'd like to talk about or focused on, in particular with obviously the COVID pandemic and differences as far as that goes for the people you take care of?
Yes, well, we have a number of pathways in which we operate and get out into the community. One of them is, health fairs, the kinds of things that typically occur in the community where you can get people out, get different screenings done, have different conversations with them about, again, these types of topics and how their service might have played a role or be associated with some of the issues that they're having. And so obviously with COVID, we haven't been able to do that in a face-to-face level, but we've done quite a bit of it virtual, holding virtual health fairs, if you will. Another mechanism is, again, having these same kinds of conversations with veterans and their family members themselves directly. So many, particularly those who have service-connected disabilities, but who are having some issues perhaps navigating the system, having some difficulty even understanding what their benefits are. So we hold forums where we directly address those kinds of things, give them additional information. The VAs themselves have a ton of information around this. Somehow there's a bit of a disconnect in terms of veterans knowing that that information is there, or at least how to access it. And so we try to connect those two, because they do a superb job with providing the information that's needed. Veterans just sometimes have difficulty connecting with that information. And so we facilitate that, if you will. And then another way that we do this is like what we're doing tonight, where we partner with organizations to educate civilian healthcare providers on some of these unique issues around veteran health, very much like the ocular diseases we were talking about tonight, but also things like Iraq, Afghanistan, war, lung injury, the particulate matter that they breathe in, particularly from the burn pits, et cetera, both from Gulf 1 and Gulf 2, and how those things impact their health. And then we also have a tool where veterans, wherever they're located, can go in to our website, put their zip code in, and if they're having an issue with health, with finances, with food, with housing, they can put their zip code in there, and it will bring up all of the organizations, some veteran specific, some just organizations who are willing to help. And they will provide the names of those organizations who help veterans attain those services that they need, either at very low cost or for free. And so that's how the foundation sort of comes together and operates down those different pathways to facilitate the health and wellness of veterans and their families.
That's great. That's really great. This is a great question that kind of bookends some of those discussions from the audience, and I'd like to hear from Dr. Sweet and Dr. Ferrucci on this as well. What sort of virtual options were you offering, if at all, in the VA system during the pandemic? Obviously, this was a time where everyone was exploring virtual. What did you use? Was it effective? Would you reuse it again?
I can.
Why don't you go, Irina?
Okay. I'll say that the year prior, in 2019, I established a Tele-Oct reading program, and Steve knows that well. knows that well. And so what that was meant to do is that a patient could get their OCT read by a retina specialist from a satellite clinic that had an optometrist. And so we used that a lot during COVID, that patients didn't have to come in necessarily to see a retina person, but we could look at an OCT taken from a satellite place. That to me was very useful that we had that established and in place the year prior. Other than that, I know plastics use the video service a lot, but for retina, where we need an exam, it was not as useful to have a video visit. How about you, Steve?
Yeah, I concur 100%. The way that we can show images, whether it's a photo or an OCT, over to your clinic and get an opinion has been super helpful. We've done some video stuff for the patients, but unfortunately, as we know, eye care it's not perfect. I mean, if I had a patient with a subconch heme or something like that, we were able to take care of things like that. But patients complaining of decreased vision through a video call with the patient, unfortunately, we weren't able to take care of much. But we did as best we could. At least screening those patients and talking to the patients and deciding, is this something that really needs a visit to the clinic, or is this something that we can handle elsewise?
Yeah, it's great comments about that. Yeah, it was hard because we could not really do things that we take for granted, like standard visual acuities and that. But yes, I think obviously using our imaging technologies as you're doing in that kind of way, and almost a hybrid sort of way, if you want to call it that, is a great way of thinking about it. We were talking, Dr. Ferrucci, about sort of the treatment paradigms with this condition. And talk to me a little bit about ultra wide field versus standard imaging for your patients for diabetes. This has really become the standard of care for patients with retinal conditions.
Yeah, you directed that towards me. Is that what you said?
Either one, Dr. Swee.
So I think a couple things. One, studies tell us if you don't look in the periphery in these patients with diabetes, you're going to miss diabetic retinopathy, and you're going to miss classifying those patients, in general, if you don't look in the periphery. And then, and Dr. Sway can talk more to this point, but, with now the wide field fluorescein angiography, we're seeing, ischemia in the periphery, and sometimes even neovascularization in the periphery that we really didn't appreciate on a clinical exam. So I think it's really helping us, find patients with meaningful disease sooner than we would have without this technology. And I'll get Dr. Sway's opinion on that.
Absolutely. So we got Optos FA pretty early on, and we just use it more and more. So almost every diabetic patient with NPDR or worse, or retinal vein occlusion gets an FA at some point. And it's very helpful. We pick up things that we didn't see on clinical exam all the time.
That's yeah. So I agree. I think it's become sort of our standard of care for diabetes patients. For AMD, we still do some macular FF450 cameras, things like that. Dr. Sweet, you mentioned about the whole idea of treat and extend paradigms, and one of the things I'm always struck by is the lack of really good randomized clinical trials with some of these conditions, especially in the diabetes realm. Can you talk a little bit about some of the data around the diabetes treat and extend paradigm, and if you use treat and extend in that realm as well? You mentioned it for AMD, but I don't know about treat and extend in DME, if you use that as well.
We do. It's pretty individualized to patients. So there are some patients, if they want to minimize coming to clinic, then we offer that. And others really want to get more injections and the best visual gains and the most visual gains possible. So to answer your question, I do use treat and extend for diabetic macular edema as well. But it's almost like when in doubt, we treat, because it helps everything. It helps the retinopathy. And so we tend to offer it to patients, and most patients want to be treated, let's say, if there's symptoms. Yeah.
That's great. Well, I wanted to thank all of you tonight for your program, Dr. Lewis, Dr. Ferrucci, and Dr. Swee. Thank you all for watching this program. This program will be archived for future activity. So if you are watching this as an archive, you can still submit for CME or CE credit. And for those of you watching again tonight, you will receive an email for your credit at the end of today's program, and that will allow you to receive either your CE or CME credit. So thank you again for your participation. Thank you again to the audience, and have a good night.
Thank you. Right.